So our next speaker is Dr. Sammy Saab. Sammy just came back from a world tour from Saudi Arabia giving talks. He is going to talk to us about hepatitis C and new therapeutic paradigms. Sammy.
Well, good morning, everybody. Steve Hahn's always a hard task to follow. I just want to say, so happy to see a lot of familiar faces. People I haven't seen in years from Vegas and some friends from Bakersfield, Sacramento, all across the West Coast. So my task in the next 15, 20 minutes is talk about hepatitis C. And this is a very, very exciting area. There are so many new things coming on right now. In fact, my last slide is a summary slide of an ID meeting called CROI. So in the next 15 minutes, we're going to cover 3 specific objectives. We're going to talk about the new CDC guidelines regarding hepatitis C screening. We're going to touch upon limitations and advantages of current antiviral therapy. Drugs were FDA approved about 2 years ago. And lastly, touch upon what's coming up in the future. And the future may only be 6 months away for certain therapies. So for the past few months, the CDC now recommends that we should start screening hepatitis C, not only based on recognized risk factors of sharing needles, transfusions, etc., but screen also based on age. And the rationale behind this is that over 80% of all hepatitis C is found in baby boomers. The CDC now recommends screening all baby boomers for hepatitis C for 3 reasons. One, hepatitis C is most frequently seen in baby boomers, people born between 1945 and 64. The CDC also says if you do the math, and you realize it takes 2-3 decades for people with hepatitis C to develop liver problems, like cirrhosis, liver cancer, failure. If you do the math, that means we have a large segment of our population today with hepatitis C who has advanced liver disease. And as you know, hepatitis C now is the most common indication for transplant in this country, if not the world. Another reason is we have very effective drugs today that we could cure 7 or 8 out of 10 patients with hepatitis C. And most people only require 6 months of antiviral therapy. And lastly, if you've got advanced disease, people need to be screened for liver cancer. Told to stop drinking, right? And no smoking, right, Myron? What's smoking good for? Nothing. All right. Focus, Myron, focus. All right. So hepatitis C, right? If you do the math, about a large segment of our population today has advanced liver disease. And Myron's co-director of a very large hepatobiliary clinic that deals with epidemic of liver cancer. And this clinic that meets once a week is full to capacity. Now, I love this slide. Because it shows that we crossed the line. It shows that in 2006, hepatitis C kills more people than HIV and even hepatitis B combined. In fact, if you look at people with HIV, what are they dying of? That's right, liver diseases, hepatitis C. Hepatitis C. When I was in training, people died of TB, MAI, MAC, CMV, PCP. Now they're in liver diseases. So we have someone have hepatitis C. What are our goals? Our goals have someone live longer. How am I doing with time, Myron? A lot of time? Good. All right, I got 50 more slides. Actually, bless Myron's heart. Over the weekend, he went through my slides, started cutting slides out, and hurt my pride. I put a lot of work into those slides. So the ultimate goal of hepatitis C therapy is have someone live longer. We saw a patient last week. I came in a wheelchair, 74 years old. I want my dad to be cured of hepatitis C. Came in a wheelchair, had a stroke, had a heart attack. I go, listen, he's doing great. he's going to live longer with hepatitis C than without it. But I can make him very, very sick with antiviral therapy. I can't make him better. So when you talk about treating someone, it's a very complicated question. And in my mind, you go through all these issues. Their genotype, their subtype, how much liver damage they've had. Have they had hepatitis C for 5 years or 20 years? Are they going to get pregnant? Or their partner's getting pregnant? Do they have cryoglobulinemia, devil lymphoma? Are they co-infected? Have they had a liver transplant? Are they motivated? So we had a patient come not too long ago, took antiviral therapy several years ago. I want to be treated again. I want that drug X out in the Wall Street Journal. Well, how'd you do before? I tried to commit suicide. This is not a good time for you to be treated again. Maybe we can hold off a little bit longer. So, and this is an old slide you've seen in all the talks. How we've gone through the evolution of hepatitis C therapy. And it's been so exciting. When I was in training, we had liver enzyme, not a viral load, to gauge antiviral therapy efficacy. And we were excited to let ALT go from 95 to 26. We didn't know what it meant, though, but we were excited. And a couple years ago, new drugs, new generation antiviral therapies that are direct-acting agents that attack the virus at its heart. If you think about what was the first indication for interferon? That's right. I heard it back there. Harrison leukemia. That's right. Lymphoma, hepatitis B, non-A, non-B. And then hepatitis C comes along. So when we have someone on therapy, it is on taking an antibiotic for a cold or ear infection or bladder infection. There's an issue of probabilities. Is there an earthquake? Is that me? All right. So people could be a sustained viral responder, which means that when you stop the therapy, the virus stays gone. Or there could be relapse, or when you stop therapy, the virus comes back in. And that's so difficult. Imagine a patient going through therapy, they go through all these problems at work, they get hooked on Vicodin and Ativan. I'm sorry, it didn't work. What? I almost got fired, almost got divorced. And we have people who get treated with antiviral therapy, and the viral load just flatlines. Doesn't do a thing. This is a paper we wrote with one of the current fellows, Vivian In. Beautiful paper. The paper was accepted within a month of submission. And this paper highlights that, yes, I feel like Wizard of Oz. Yes, Nan, there is a cure. If you get a same viral response, that's translated to a cure. And there are about a half a dozen papers showing that if you follow patients long enough, yes, the virus stays gone in most patients. And indeed, one of the issues about hepatitis C therapy is we've always relied on surrogate markers, like a viral load. But now we've got hard data that shows that we can make a difference in morbidity and mortality. There is a stunning paper published in JAMA in the past month from Europe showing that with advanced disease, your risk of dying from liver-related problems goes way down significantly. Now, to be fair balanced about this, all about fair balance, right, Myron? See me unit. All about fair balance. To be fair balanced about this is true people with advanced disease. I cannot say that people with minimal damage, I will make them live longer with antiviral therapy. There's no studies for that. In fact, they can die of a car accident or something else. Or take a red light, like one of the green slides, and get hit by another car. Here's a virus. Simple virus, but carries a big punch. That's a phrase I got from Steve many years ago on hepatitis B, a small virus. So, and if you look at the areas, first, the viral genome is divided into two parts, structural and non-structural protein. And that's what they get the letters NS, non-structural. These are enzymes for the most part. It's a target of antiviral therapy. The only one that is not an enzyme is the NS5 area. And we don't know what that does. But attacking that is very effective for reducing viral loads. All right, so when we talk about protein inhibitor, we're talking about an enzyme that cleaves the polyprotein chain. So protein inhibitor, we inhibit that function. Right now, we talk about two FDA-approved drugs, Telaprevir, Boceprevir. These drugs have to be used with interferon and ribavirin. If you don't, we have a new concept in hepatology regarding hepatitis C. A new concept is resistance. Resistance. These drugs are not FDA approved right now for co-infected patients, people with advanced liver disease, decompensated cirrhosis, and after liver transplantation. For HIV liver transplant, the problem has been the studies looking at drug interaction. Another new concept for us in hepatology regarding hepatitis C. In decompensated liver disease, you can make someone really, really sick. And in fact, I don't know if I have the slides, but there's a study called Cupic from France that looked at decompensation in people with advanced liver disease, and it was almost 5%. Here's kind of a summary slide of the viral response rates in treatment-naive and treatment-experienced patient. Across the board, you see a significant improvement compared to people who are on interferon alone. Can I go back? Oh, yeah, here it is. Significant improvement among naive patients and treatment-experienced patients. With the addition of a medication to the interferon backbone, a huge improvement in SVR, Telaprevir, and Boceprevir as well. But other new concepts are futility rules, stopping rules. If people's viral loads are not suppressed significantly, adequately, we've got to stop therapy. Why spin your wheels if it isn't going anywhere? All you can do is invite for more adverse effects, more cost, and maybe breed resistance. There's no free breakfasts or parking, right, Myron? No free meals. Everything comes at a cost. So these drugs associated with some significant incremental improvement in cure rates, but they come at a cost, adverse effects. So Telaprevir talk about a rash and over half the patients, fatigue, anemia, and the ring of fire. Oh, you guys all know what the ring of fire is, right? Anorectal rash. Anorectal rash. Anorectal rash. With Boceprevir, the side effects are also higher than that you see on interferon ribavirin. But it's a new side effect called dysgeusia. Now, what's dysgeusia? I was at a talk in Northern California, and they go, oh, that's an Italian dish, right? I saw the menu. I'll take one to go for my family. It's a funny taste in your mouth that you see with Biaxin or Flagyl. But one thing I want to come across is the side effects of antiviral therapy. They're predictable, they're manageable, and for the most part, they get better with intervention. So if someone becomes anemic, I know what drugs did that. I know how to intervene. I know how to improve that. Oh my God, it's a big slide. Gary's probably sweating right now. Oh my God, I told him no busy slides. I learned that from his talk. All right, the point of this slide, don't read the whole thing. The point of this slide is to just highlight the drug interactions. So when we had to do the interferon only, we were happy. Not much drug interaction. In fact, what we had was methadone. And that was great. Methadone levels went up in the blood. People are all happy. Compliance was wonderful. Now we got to worry about stuff like rifampin and statins. But let me tell you, you have someone on rifampin for tuberculosis, hepatitis C is the least of the concerns. Least of the concerns. Other drugs like cisapride, we haven't used in a decade. The one we have to worry about, to be honest, are statins, so commonly prescribed. In fact, I'm on it now, Myron. And the other one we got to worry about also are the birth control pills. So women who are on birth control pills, they have to use another form to prevent pregnancy. This is how looking at resistance. Unlike Dr. Hahn's talk on hepatitis B resistance, where people get the gift that gives on giving, once you get hepatitis resistance, it's there for life. Hepatitis C is fascinating. We don't have a reservoir for mutant viruses. So over time, the resistant variants actually go away. Go away. But there are challenges. These drugs have adverse effects, anemia, rashes. You take drugs every 8 hours. you know, and depending on using Boceprevir, Telaprevir, different strategies. They're not interchangeable. Interference with the cornerstone therapy, and issue resistance, and cost. Not only the adverse effects, but the financial impact. The financial impact, both direct costs, indirect costs. I don't know about you, Martin, but I filled out so many disability paperwork in the past couple of years, more than I've had in the previous 10 years. Drug interactions, and we've come a long way in terms of subpopulations, treating African Americans, Latinos, people with cirrhosis, but we have a long way to go still. So right now, the drug that's FDA approved are Boceprevir and Telaprevir with interferon ribavirin. You know, we think in the next 8 to 14 months, we'll have two new drugs FDA approved. A polymerase inhibitor and also an NS5 inhibitor. So the slide is busy on purpose. It's busy on purpose to show how complicated hepatitis C therapy will become in the next several years. Look at all these different classes of drugs. So the challenge for us will be how do you pick one regimen over a different regimen? And can you combine drugs from different classes? So this slide is meant to be busy on purpose. These drugs are going to differ in terms of the potency, in terms of virus suppression, barrier to resistance, issues of drug interaction and adverse effects. And a new term for us, pangenomic. They're going to differ in terms of treatment genotype 1 only, or are these drugs efficacious against genotype 2, 3, etc. etc. So one of the drugs we think would be FDA approved in the next, I don't know, Martin, what do you think, 6 months, 8 months? The company's already submitted in Japan to get approval this week. It's a second-generation protein inhibitor. Second-generation protein inhibitor. It's taken once a day, and it's taken with interferon ribavirin. And look at the results. People treated for 12 weeks, 24 weeks, SVRs between 75 and over 80%. Once-a-day drug. Anyone see any problems with this slide? I see a big problem. I see a big problem that makes me uncomfortable is a control arm. Where did they recruit these patients? 65% SVR in the control arm? You know, unless you got CC genotype and people's thin, and you know, it's hard to get that. So, I take this with a grain of salt. On the other hand, it's very well tolerated, very well tolerated. And patients who are treatment experienced, drugs also very effective for relapsers, partial responders, and no responders. Another drug we think would be FDA approved later this year, early next year, by a company called Gilead using a polymerase inhibitor once a day. And for genotype 2 and 3, in naive patients, for 12 weeks of therapy, SVR, I want to say close to 100%, but it's not really 100%, close to 100%. This is from an abstract from a liver meeting. There's been a number of press releases since then, show true numbers a little lower, and it was fascinating. The numbers are lower for genotype 3 than genotype 2. In addition, if you're cirrhotic, the numbers are significantly lower for genotype 3, significantly lower. This is from a press release last week. Look at treatment-experienced patients. Now, we don't have any 6-month SVR. We do have 12-week SVR. And we see that for genotype 2 and 3, for a treatment-experienced patient, the cure rate is between 86 and 94%. Genotype 3, between 30 and over 60%. The range differ if you're on different duration of therapy. It's a paper published just last month in New England Journal of Medicine looking at using Abbott combination, or actually Abbott V, using different medication, oral medication, and you see these drugs are very, very effective and naive, patients as well, no impartial responders. Very effective. This study published by Anna Locke looking at genotype 1 patient using 2 oral drugs of NS5 inhibitor. I think it's a protein inhibitor as well. And you see on the top left-hand corner that these drugs are very effective initially. The viral goes down, but what happens? The virus comes back up again. But when you do the same study using with interferon ribavirin, everybody had viral suppression. These are no responders. No responders. With interferon ribavirin, it's 5% cure rate. With triple therapy, around 30%. Here you have close to 100%. But you had to use it with interferon ribavirin. And this study published recently in Hepatology showing the same 2 drugs in Japan had 100% cure. So what's the difference between the US population and the Japanese population? That's right. I heard that back there. The genotype, subtype. In the US, we have mostly genotype 1A. In Japan, 1B. So knowing the subtype may impact what drugs used in the future. And people who can't get treated right now, what else do we have to offer them? Coffee. Coffee is good for you. Coffee is good for you. It's not one of my disclosures, huh? I should put that up. I won't stock in Starbucks. Coffee is good for you. Dr. Tong and I are writing a review article on the impact of coffee in liver diseases. And it's been shown to help liver enzymes, help alcohol liver disease, help hepatitis C progression. Studies by NIH showing that people drank coffee, their hepatitis C progression much slower. They drank between 2 to 3 cups a day of coffee. This is, I think, the last slide. And the point on this slide is to highlight how this area is moving so quickly. This is an ID meeting this week, looking at using different combination therapies in co-infected patients and no responders. So the challenge is keeping up with new information. At this point, I want to thank you for your attention, and thank the organizers for letting me speak today on hepatitis C. Thank you. Thank you, Mario.